A Synoptic Esophageal Cancer Pathology Report. Welcome to today's episode, where we delve into the intricacies of esophageal cancer pathology. Today, we present a comprehensive overview, tailored for medical professionals and enthusiasts alike, offering insight into the diagnostic and prognostic factors that shape patient care and outcomes. Patient and clinical details. Our case centers on Robert Johnson, who underwent surgery for cancer of the esophagus. The operative procedure performed was the Ivor-Lewis oesophagectomy, which involves removal of the distal segment of the esophagus along with a portion of the stomach, followed by reconstruction through a gastric pull-up technique. Prior to surgery, Mr. Johnson was diagnosed with adenocarcinoma located in the lower part of the esophagus, confirmed by biopsy, and received neoadjuvant chemotherapy using a regimen known as FOLFOX. Specimen overview. The specimen consisted of an 8 cm section of esophagus and a segment of gastric cardia. The surgical margins were carefully marked, and lymph nodes within the surrounding tissue were also retrieved for examination. The tumor presented as a firm, irregular, and ulcerated area situated 2 cm above the junction between the esophagus and the stomach, measuring 2.5 by 2 cm. The mass was accompanied by a fibrotic and thickened underlying wall. Microscopic findings. Microscopic analysis revealed a moderately differentiated adenocarcinoma arising in a background of Barrett's esophagus, which exhibited high-grade dysplasia. The effects of preoperative chemotherapy were evident, with marked fibrosis and only rare residual cancer cells present. Approximately 10% of the tumor tissue remained viable following treatment. Notably, the cancer infiltrated into the submucosal layer but did not reach the muscular layer of the esophagus. There was no evidence of cancer spreading into blood vessels or nerves. Surgical margins and lymph nodes. All examined surgical margins, including the proximal and distal ends as well as the circumferential radial margin, were free from tumor involvement by distances of at least 1 mm. In total, 25 lymph nodes from the region surrounding the esophagus and stomach were analyzed. None contained metastatic cancer cells. 3 lymph nodes displayed extensive treatment-related changes and infiltration by special immune cells, but there was no residual tumor detected. Pathologic staging and biomarker staging was performed according to the latest edition of the American Joint Committee on Cancer Guidelines, reflecting the assessment after neoadjuvant therapy. The tumor invaded the submucosal layer and was designated as stage 1, with no lymph node involvement and no evidence of distant spread. Biomarker testing for human epidermal growth factor receptor 2 was negative, indicating no overexpression of this protein, which is relevant for targeted therapy decisions in metastatic disease. Key elements of esophageal cancer pathology. It is crucial to highlight the unique aspects of esophageal cancer pathology compared to other malignancies. Adenocarcinoma is the predominant type in Western countries, often associated with Barrett's esophagus. Squamous cell carcinoma, conversely, is more prevalent globally and linked to tobacco and alcohol use. The location of the tumor, notably its proximity to the junction of the esophagus and stomach, determines the appropriate staging system and influences management decisions. Most advanced cases receive chemotherapy and sometimes radiation therapy before surgical intervention. The degree of tumor regression after such treatment is a key prognostic indicator, with less residual cancer signifying a better outcome. Depth of invasion and the status of the circumferential radial margin are vital for assessing the risk of recurrence. The thorough examination of lymph nodes, ideally at least 12 to 15 or more, further informs prognosis. Biomarker assessment, including human epidermal growth factor receptor 2 and programmed death ligand 1, guides the use of targeted and immunotherapies in advanced disease. Conclusion. This report demonstrates an excellent response to preoperative chemotherapy, resulting in a favorable pathologic stage and prognosis. The absence of lymph node involvement and the lack of residual cancer at surgical margins are both positive indicators. Such comprehensive pathology reporting is essential for guiding postoperative management and informing patients about their outlook. Thank you for joining us on this episode. If you found this discussion informative, please like, share, and subscribe for more expert content on surgical pathology and cancer care. Stay tuned for future episodes where we continue to dissect the extraordinary in medicine.